Ladies, let's talk about something that isn't always easy to bring up. If you've ever found yourself rushing to the bathroom more than usual, leaking a little when you laugh, sneeze, or exercise, or feeling a heaviness down there that you can't quite explain, well, you're not alone. Urinary frequency, urgency, and incontinence and pelvic organ prolapse are health issues that has become more common. But that doesn't mean that they're just a part of life that you have to accept. Today we're diving into what causes these changes and what they mean for our health, and most importantly, what we can do about them. I'm joined by Dr. Kretzer, a board-certified obstetrician gynecologist from Full Spectrum Fibroid and Endometriosis. She specializes in helping women navigate these concerns. She's going to break down the myths, explain some of the science, and share real solutions that can help you regain confidence and control. So grab your coffee, get comfortable, and let's have this conversation, because your health and your comfort and, of course, your quality of life matters.
Yes.
Dr. Kretzer, thank you so much for joining us.
Thank you for having me.
So, what are some of the common causes of urinary frequency, urgency, and incontinence? And please explain anything else that's probably the common questions with those.
Okay. Yeah, I think everyone notices as they get older, they start to have to pee a little bit more frequently or get up a few more times during the night. So there is some level of urinary symptoms that just occur with aging. But if it's bothering you and it's affecting your quality of life, there are definitely things that we can do about it, and you don't have to suffer in silence.
Okay. What's the difference? Because I also understand that when you have to go to the bathroom a lot, sometimes that's diabetes. Is this different than that?
Yes, this is very different than what can happen with diabetes.
Okay. So urinary frequency, urinary urgency, what's the difference?
So urinary frequency is how often you go to the bathroom. And so women that have it affecting their life frequently have to go almost every hour or even less than every hour. And they find that they're not completely emptying their bladder, or they're having very low volume voids, but very frequent. So that would be frequency. And urgency is more of a symptom that when you feel like you have to run to the bathroom. Otherwise, you're not going to make it in time. A very common explanation that I hear from patients is when they get home, they weren't really thinking about their bladder, but as soon as they put their hand on that doorknob and they start to turn that doorknob, they feel like they just have to get to the bathroom right away and feel that urge to go.
Okay, is that the same as incontinence?
So incontinence is when you actually leak urine. And so that can happen with urgency, but it can also happen with other forms of bladder dysfunction. And so part of the workup for women that are experiencing the symptoms is trying to figure out what different pathophysiology is underlying their symptoms, and because they each have different treatment modalities.
Okay, and what is pelvic organ prolapse?
So the pelvic organ prolapse is essentially a vaginal hernia. So everyone kind of has heard of like abdominal hernias, where the muscles on their abdominal wall weaken and things start to protrude through the wall. The same thing can happen in the vagina. The connective tissue gets weak with age. There's a lot of things that are associated with pelvic organ prolapse. The number one risk factor is if your mom had it or genetics, you're more likely to have it. But there are other factors. And over time, the top of the anterior wall, so near the bladder, or the posterior wall of the vagina near the colon, or the uterus itself, can start to weaken and fall down. And that's pelvic organ prolapse, and can also contribute to these symptoms because your bladder is intimately related with the anterior vaginal wall.
I have never heard of that before. So is it not that common, or is just People don't talk about it.
I think a lot of these things are more common than we are really aware of. I think we are now as a society becoming more comfortable talking about these things and looking for solutions. And so I think it is extremely common. There's different stages of prolapse. And so it really doesn't start to become symptomatic until stage 2. But it is extremely common, and there are things that we can do to help women have improved quality of life.
So, can you explain more about the incontinence side?
Yeah, so incontinence is leakage of urine, and there can be many main causes of that. But the two main things that happen as we age are urgency incontinence or stress incontinence. Stress incontinence is when you have leakage with like coughing, sneezing, jumping, or running. And that is because that occurs a lot of times because the urethra, the tube that goes from the bladder to the outside world, the tissue around that kind of weakens over time, and the urethra just isn't able to withstand the increased pressure when you cough or sneeze and isn't able to keep the urine in. So the first evaluation that we do is to kind of tease out what type of incontinence you have. And if you have stress urinary incontinence, we can fix that either with a device called a pessary, which is a disc-shaped device that you put in your vagina and it kind of holds up the urethra, or we can fix it by doing a surgery. And there are two types of surgery that we can do to help with stress urinary incontinence. One is something called a sling. You might have heard of that. It's like a hammock that you put under the urethra with mesh, and that supports the urethra. Or you can do something called bulking, where you inject into the muscles of the urethra a bulking agent, so it gets thicker. So then it's harder for urine to get out that hole because it's thicker.
I guess I thought that as we get older, pretty much being in diapers, adult diapers, was a fact of life, like just accept it. So are you saying that can actually be avoided?
Definitely. It may not have all of the solution to surgery because that particular surgery only fixes the stress component of incontinence. And if you have additional incontinence, like from urgency symptoms, like an overactive bladder, that we can fix with medication. So there are things that we can do to treat both. And the goal is that you aren't having to wear a big diaper every day.
So is it just that there's like a lack of knowledge? Because I've never heard before that there was a treatment for incontinence ever.
Yeah, I think it's just something that women don't tend to talk about. They are probably embarrassed about it, and they tend to like isolate themselves when they're having these symptoms because they don't want to have accidents in public. And so, treating these symptoms can really help improve quality of life and overall mental health as well.
Yeah, especially if it turns out that you only need medicine.
Yeah,
That's pretty
medicine
good.
or a pretty straightforward surgery.
Wow. So how long does a surgery like that takes, and I guess you could say, what's it called? The recuperating time
The
frame.
recovery.
Recover.
The surgery itself for the sling is really a short surgery. It's only 1 to 2 hours. And the one for the bulking can be 30 minutes to an hour. And recovery for bulking is really, there's no incisions. It's just injection with a needle. So you pretty much recover right away. And recovery after the sling is usually a few weeks of lifting restrictions. And usually as we age, we're not doing heavy lifting or doing a lot of running. And so it's just a few weeks of those type of restrictions.
Okay, so are these options something like if my aunt were to go to her gynecologist, is this something where maybe a typical gynecologist, I don't know if that's the right word, typical, may not know about these other options, only as someone like yourself is the better place to go because you're more aware? How does that work? Because again, I've never heard that there's other options for
Well,
incontinence.
yeah. Well, general gynecologists should be trained about all of these things in their residency. It's a part of the residency curriculum, but we may not see it that often or have exposure to those parents. So a general gynecologist tends to do both OB and GYN. And so they spend a lot of time doing obstetric care. Usually it's about 50 to 70% of their practice. So they just don't have as much time to devote to these issues. And so that's why one of the reasons why I specialize only in gynecology, so I can focus only on these complex issues. And there is a fellowship specifically for the specialty, urogynecology, to also focus on these issues. And that's where I got my additional training, was by working with some urogynecologists.
Okay. And are these treatments covered by typical insurance, Medicare,
Yes.
Medicaid?
Yes, a lot of these patients, especially as you get older, tend to have Medicare, and these treatments in general are
A
covered.
lot of these changes are normal as we get older. At what point does one need to seek medical help?
So I think as soon as it's becoming bothersome and making it so it's changing what you do. So I have some patients that are like, I just don't want to leave my house anymore because I always have to know where a bathroom is because I know I'm going to have to go. And so if it's affecting you, we can look into it and try to help you so that you can have improved quality of life. In terms of prolapse, a lot of women seek help for that when they start to feel it. They start to maybe feel or see a bulge coming out of their vaginal opening. And when it's to that extent, that there's definitely things that we can do to fix that.
That's interesting. I think if something like that occurred, I would think that it's a fibroid or something, because that's what you hear about all the time.
Yeah, actually, women that have large fibroids don't tend to have prolapse of their uterus because the fibroid kind of is helping hold it up due to its size. But yeah, the bulge that women see usually is the vaginal wall coming down, either due to the uterus falling down and kind of pushing it out, or due to like the hernia of the anterior or posterior wall.
Wow. So before one gets to where they need major medical treatment, are there any lifestyle changes or exercise, anything that's preventative that one can do to reduce some of the symptoms?
So you can do pelvic floor physical therapy. I personally I think all women could probably benefit from pelvic floor physical therapy because it can help strengthen your pelvic floor muscles. And you can also do bladder retraining as a part of your pelvic floor physical therapy, which helps you learn some tips and tricks on how to kind of do Kegel exercises to tell your bladder to calm down with urgency symptoms.
Okay, so what is that? Is that because I think I've seen the machine that you put a tool or whatever you could put between your legs and squeeze it or whatever, or I've heard of urinate, hold it. Is that what you're referring to?
So bladder retraining has to do with the urinary frequency and urgency symptoms. And so when we counsel women kind of conservative measures for that, we talk to them about, holding your bladder like 5 minutes longer than you normally would and continuing to do that in order to extend the time in between when your bladder is firing. When you have urgency and frequency, you can have something called overactive bladder, which just means that the muscles of the bladder are just firing too much and they're firing at low volume and telling you that you need to go to the bathroom. And so training your bladder to be able to fill up a little bit more every time gradually will increase your capacity and make it so you don't have to go as often.
So every woman should do those exercises, no matter what.
Well, you can, like, especially if you're starting to have symptoms, but there are specifically pelvic floor physical therapists that you can go see as a part of physical therapy that also do work to help train the muscles and pelvic floor.
I've never heard of that before.
Yeah, it's not a very well-known part of physical therapy, but it is very helpful to women, especially women that have pelvic pain and we don't think about using our pelvic floor very often, and so definitely those muscles can become weak over time.
Okay. So of course you're the doctor. I'm just the woman here with all these. What is a pelvic floor?
Yeah, the pelvic floor is the muscles that support everything in your pelvis. So your pelvis is like a bowl. So you can think of the pelvic floor as a bowl, and through that bowl you have, well, on top of that bowl you have your bladder and your uterus and your colon, and then they actually go through the bowl to exit your body, right? You have your urethra that goes from the bladder to the outside world, going through that pelvic floor. You have your vagina, and then you have your rectum. And so the pelvic floor is all those muscles that support those structures.
Oh, okay. What actual, I guess, services, what treatments do you guys provide at Full Spectrum? And what are some of the common, I guess you could say, complaints that patients have coming in that you treat?
So if I have a patient coming in that's telling me that they're having urinary frequency, urgency, urinary incontinence, or prolapse, all of those things I work up kind of together because they're commonly found together. And so the evaluation involves getting kind of a bladder diary or finding out how much are you drinking? How much are you urinating? Are you having many small frequent volume voids? You know, a woman should urinate as much as they take in. So as much as you drink, you're going to drink, put out. And so are you drinking too much? And maybe does decreasing the amount of fluids you're taking decrease the amount of times you're going to the bathroom? Or is there something like an overactive bladder that we need to treat? So the first step is just, you know, getting a history and finding a bladder diary. And then we want to make sure there aren't other causes, like bladder infections can lead to these symptoms, urinary tract infections. And as we get older, we may not have the traditional symptoms like pain with urination. And so getting a urine sample and making sure that there's not an underlying infection is important to rule out. And then doing a physical exam. And during that physical exam, I do a pelvic exam and I examine the vaginal walls. I examine separately the top and the bottom and see if they're falling down. Do they fall down at baseline or do they fall down like when a woman pushes down, because that can make them come out even further. Sometimes women don't feel their prolapse until they're standing up because gravity is pulling those organs down. And so doing an exam both while the patient is lying down or while the patient is standing up is important. And then finally, I also have the patient urinate, and then I test how much urine is left in their bladder. Because if you're not completely emptying your bladder, then you're at risk for your bladder eventually becoming too full and affecting your kidneys. And that can be a cause of symptoms if you're not able to completely empty your bladder. So we need to assess for that as well.
Okay. Is it normal to, like, sometimes I find I have to go to the restroom and I think I have quite a bit in there and then just little drips come out. And I'm like, okay, is that normal as we get older?
It can, yes, that can happen more frequently when you get older. But if that is happening, we definitely want to make sure that you, at some point, you are emptying your bladder completely.
Oh, wow. Okay. And then I'm sure other women can relate to this as well. Sometimes if I have a road trip, maybe if I know if it's going to be an hour, I purposely will limit how much I drink as far as water because I don't want to be stuck out on the freeway and traffic or whatever and I can't get to a restroom. Is that a normal issue?
That is also a normal issue. Like I said, what you put in, you generally put out. I mean, there is water and fluid in food that we eat, so it's not just what you're drinking. But in general, if you drink more, you're going to have to urinate more.
Okay. So you mentioned that you guys test sometimes to make sure that your patient isn't drinking too much. My first thought about that, because we're always told 8 glasses of water a day. So how does one balance that out? Because we need our water,
hmm
but
Yeah, it's really tricky because that is what a lot of people are saying is to drink a lot. I think that's fine unless you're having these symptoms. And if you're having the symptoms and I find that you're drinking more than 2 liters a day, we will attempt to decrease that just to see if you feel better. There's also uh, there's a dietary component. There are bladder irritants, which unfortunately tend to be all the things that we really enjoy, like chocolate, alcohol, tea, coffee. Those things can be irritating to the bladder and also cause you to urinate more frequently. And so avoiding bladder irritants can also help improve the symptoms.
I love my coffee.
I know it's a hard thing to do.
I'm not a big chocolate person, but my coffee, that's the first thing in the morning.
When we work these things up, we try to do these conservative measures, decreasing the amount you drink, avoiding bladder irritants, making sure you don't have an infection, and making sure that you're able to empty your bladder. And then if we go through all of that and you're still having these symptoms, that's when we start treating either medically, or eventually there also are some procedures that we can do to treat.
Okay.
And you can have incontinence separate from all of that. And there are two main different types of incontinence, and depending on which one you have, either it's a surgical or solution, or it can be a medical solution.
Wow, it's always something. What is on average, the process of, I guess, the first initial, I guess, tests that you're doing, observations? How long can that last before you possibly get to, well, we have to go into more treatment?
I think as much as the patient is willing to tolerate. Usually by the time you get to me, the patient is already, ready to try something else. And so, if there are things that I can outright see that is irritating them, like the dietary irritants, we'll try it. But if it's not helping a lot after even just a few weeks, then I think that's when I start moving on to working up more of a medical or a surgical solution.
Okay. So medical is medicine versus, okay.
For example, overactive bladder can lead to something called urge urinary incontinence. And that's when, if you're running to the bathroom after getting home and turning that doorknob and you lose urine, that's urge incontinence. And so that, along with the overactive bladder, the next step in treatment is medication. And there are two main classes of medication that we can try in order to see if that improves your symptoms.
Okay, that's good for the surgery shy patient.
Yeah.
That you don't jump immediately into surgery. So
That's correct.
please share more about Full Spectrum, and if anyone lives in your area, how they can seek you out to possibly become a patient. And if they're not in your area, what should they look for as far as a specialist similar to you near where they are if they can't get to you?
So if you're having any of these symptoms, there's something that we can help you with at Full Spectrum Fibroid and Endometriosis. We didn't talk a lot about the stress incontinence or the prolapse, but those can both also be managed conservatively with something like a pessary, which is a device that holds things up in the vagina, or we can do a surgical solution. And those are things that, as a gynecological surgeon, I'm trained to do as well. If you're not in the area, some gynecologists have special training that they've done after residency to really help treat these symptoms. And then there's actually a whole specialty that is fellowship in gynecology called urogynecology. And urogynecologists, really, that's all they do, is they treat patients that have these types of symptoms.
And that's one of your specialties.
So I'm not a urogynecologist, I'm a general gynecologist, but I worked in a urogynecology office for 3 years. And so I have gotten additional training beyond my my residency training in order to help treat these issues. There are still, when a lot of treatments fail, there's still things that I'm not trained to do, and I would still refer to a urogynecologist. But the initial workup and the initial treatments is something that I am able to provide for patients.
Okay, wonderful. Please let the ladies know where Full Spectrum is.
Full Spectrum is in Seattle, Washington. And if you're familiar with the Seattle area, it's in the location of Ballard, which is kind of on the northwest side of Seattle.
Perfect. And you actually, ladies, we just had Dr. Winter on a couple weeks ago speaking about what her part at Full Spectrum, and you two basically work together to keep women healthy.
That's
Yes,
correct. She specializes in kind of problems in younger women, and we actually operate together. So all the surgeries that we do, we're in the operating room together as a team.
perfect. Thank you so much, Dr. Kretzer, for joining us. So, ladies, seek them out for any advice, any, symptoms that you're not sure about, just to get yourself completely healthy and whole.
Yes, we're happy to see you.
Thank you.
Thank you.